Health Television on TSTV. Um, Today we are going to discuss another group of non-communicable diseases, but this time it's going to be about good evening again and welcome to this program, Clear Online, airing on Africa Health Television on TSTV. Today we are discussing a group of non-communicable illnesses called cancers. And particularly this is because 4th of February every year from 2000 has been initiated to be called International Cancer Day by the Union for the International Cancer Control. The aim of that initiation is to make sure that we work collaboratively, meaning everybody in the world puts their hand on deck to work against cancer. The reason is simple. There are 10 million deaths from cancer every year. And if we leave it and don't do anything, by 2030, we will have 13 million deaths from cancer every year. But if we do something, it is possible to prevent 1/3 of that number. And if we do something further, it is possible to detect early another 1/3. And that was a very great feat. The world has come a long way concerning cancer in terms of understanding how cancer forms, and in terms of research that have increased understanding into the medications available and the different kinds of therapy. Yet, there is inequity, so much so that 65% of deaths from cancer are from low and medium income countries. Even within the countries that are developed, the inequity is there. The immigrants, among the minorities, so-called minorities, and among those who are on the low socioeconomic rung of the social ladder, there is an increased number of cancer. There is also an inequity in the care of cancer, so that it is not available. In some countries, like in Nigeria, you may not find it in more than 10 places, certain kinds of cancer, if you are looking for radiotherapy, for instance. Because of this, it is very important to ask that everybody should put his hand on deck. Now, the theme for the World Cancer Day is closing the care gap. And this theme will subsist for 2022, 2023, and 2024. But for the sub-theme for the 2022 is identifying the problems and reducing stigma. It's trying to understand the thoughts in the minds of survivors of cancer and using this to inform our attempt to program further to reduce the devastating effects of cancer. Now, today, I'm going to have several guests. They will discuss according to their fields of expertise. So I'm going to have maybe 5 guests you will be seeing in the course of the program. We'll be very happy if you remember to call. If you remember to call using the number 07 111 5342. You can use that number to call. You can also use the number to send text, and the number is 080 3291 6880. The number will be running on the screen. Please, we need to hear your perspective. Especially, I'll be glad to hear the perspective of cancer survivors, and I would like to know if there are cancer communities formed in this part of the world like it is in other parts of the world. I will begin with 2 guests here. Dr. Olusegun Ajuwon is a consultant endocrinologist. Everybody is going to have to talk about his group of cancers. You're welcome, sir.
Thank you very much for having me. Right.
Dr. Meliga is a gastroenterology specialist, and he will tell us what does that big word mean, so that our viewers can flow along. He will discuss about that. So to begin with, sir, what is cancer, and how do we, my cells are fine. How does my body say this side is developing cancer?
Well, thank you very much. Cancer, like you said, is a group of, one of the major, is a member of the group of non-communicable diseases. And it is so important because globally, cancer is a big challenge in the world, not just anywhere, that's globally. And it is poorly addressed, either because the funding for it is not always there, and there are other more pressing diseases. So you find that this is is killing so many people. The National Health Insurance in Nigeria does not quite cover many aspects, but most aspects of cancer treatment, apart from maybe consultation. The drugs are costly, and also there are misinformation and disinformation about cancer. So I agree that it is a necessary thing to look at. But what is cancer? Human body we have programmed growth. When the baby is developing inside, the cells are developing at a programmed rate, and as we grow, I will not have my nose just going longer and longer here to the eyes. So there is every system in the body is controlled, and there is something that they are controlled by genes. Of course, these are big names, chromosomes, or some secret of life that controls how a cell grows. And if a cell is too old, there are systems in the genes that are also that controls that, look, it is time for you to be removed. So there is cell death, and if a cell is damaged, there are also systems that remove them. But if something now happens to the genetic system, that a cell or a group are now out of control, and they're just developing without, it's not as if the body needs it, they're just developing and multiplying, increasing in size. All that, will say that is a problem. They know for cancer, it is not only that they increase in number, but they are also invading the surrounding tissues, and they are able to they get transferred to other sites, and eventually they kill. So it is because, so it's a genetic disease, a genetic disorder that affects the normal control. Imagine that a football is going on, and nobody has blown, so a team has said they have scored, or the referee says stop, or there is no referee, or they are not obeying the referee, there will be chaos. Yes. That's the picture you can put as what is cancer. When and it can start from any cell. Yes. So you can have cancer. That is not, by definition, we are saying that the cell is increasing, so you can have a lump. Okay. That's a tumor. But if it stays within that, if it stays within the space, its own space, yes, without moving to another one, we say that is a benign tumor. Tumor mass, we are saying the same thing, lump. But if it has a tendency to invade that's spread to other nearby system, or leave the site where it has happened and is transferred to, maybe it starts from the liver and it now goes to the lung, then we say such a growth that starts locally and is able to affect the other things around it and able to invade them or get transferred, that is what is called cancer. Okay, so because it is big, the number has increased, so you see it as a lump, and it has a tendency or a power to invade the surrounding cells, and from that site it also goes, it is transferred to another site.
So not all lumps
are cancer? In fact, not all lumps are cancer. Okay. There are some, the one that is just localized, a benign tumor. Okay. The one that has a tendency to invade and to go out is called cancer. And in fact, that transfer from one side to another is called metastasis.
Thank you very much,
right,
sir.
Right.
Now, I would like Dr. Lawrence Meliga to talk about, first of all, tell us, when you say gastroenterologist, what are the systems there? And so what are the cancers that can develop from those systems?
Thank you so much. When you say gastroenterology, actually, the name is gastroenterology and hepatology. Now, gastroenterology is the GIT tract running from the mouth to the esophagus, the stomach, the small intestines, the large intestines. Okay. Now, the hepatobiliary tract, actually, which what means hepatology, that's the liver and the biliary tract, with the gallbladder. Now, that is the meaning of gastroenterology and hepatology.
Okay. So, what are the cancers there?
Each of these organs.
I know, just to mention them, because after that, I would also like to know.
They have related malignancies or cancers. But the esophagus, that's esophageal cancer, the gastric cancer, which is the stomach, cancer of the stomach, the small intestinal cancers, which are mostly neuroendocrine tumors. I won't go deep into that. Then the colorectal cancers. Now,
so from mouth to
the rectum.
To the rectum?
Yeah, where you.
Okay.
Now, I want to lay more emphasis on the hepatocellular cancer, because that's the major challenge we have in this country.
Hepatocellular cancer.
That's cancer of the liver.
That's cancer of the liver.
Yeah.
Okay, so you will tell us what are the things, what are the risk factors?
Yeah,
how
so
do they come
I was going there.
Yes.
Now, as a doctor, as a student in gastro unit, you really don't like seeing your patients dying. You really don't. You barely can do nothing, because most of them present late with hepatocellular malignancy. And a lot of time we try to devise means of preventing this. Is very difficult, because hepatitis B virus is endemic in our environment, in our society. And if we don't tackle hepatitis B virus, what to tackle these malignancies, these cancers. So my emphasis will be more on the hepatitis B virus. The other risk factors, I will summarize.
We're not talking mainly on the hepatocellular
cancer,
carcinoma.
yes, which is the liver cancer.
B is a major,
it's a major cancer. It's a big problem for us in this part of the world.
Do you see it as a cause or a risk factor?
It's a cause, it's a risk factor. It's an oncogenic virus on its own. And a lot, like the prevalence is very high. It's about 12.2% about 2013, and lately they said it's about 8.1%. Now this improvement is because of the immunization program that has been established. You know, in the past there was no hepatitis B virus vaccination in our EPI program. Now, luckily we have that, but that is not enough. We still need to address, we need to identify those adults with hepatitis B virus, and the only way we can do that is this awareness, thanks to your program. Now, we need to encourage every adult to go out, screen for hepatitis B. If you are negative, great, get vaccinated. But if you are positive, you have to come to the hospital. You have to take it serious, because it's the cheapest means of prevention.
The cheapest means of preventing cancer of the liver.
Because if you develop liver cirrhosis or liver cancer, it's costly. Even with your money, it's difficult to actually, it's costly to even get a liver transplant done. And managing liver cancers is very difficult.
Yeah, we went to details.
We won't go. So the advantage is more in the screening and prevention. Now, the other risk factors for liver cancers, hepatitis C is also a common risk factor, but thanks recently we have a cure for hepatitis C, so which is not really of a challenge. Recently, a lot of youth, or a lot of us begin to indulge in herbal medicine, herbal concoction, and most of these herbal concoction are mixed with alcohol. So even if you don't take alcohol, is a major risk factor. A lot of people that don't take alcohol actually assume they are free. No, a lot of the herbal concoction they take are prepared with alcohol. So that's another risk factor. Now, there was a study that was done in Ife by Unduboba itself. It showed that 80-something% of the patients with liver cancer were exposed to herbal medicine. And so that's a major risk factor, and it's something we can prevent.
In our environment, what are those herbal medicine?
Yeah, you know, there's a mixture. Herbal with alcohol, with all sorts of concoction, with manual workers, even our military men and police officers. They take it on a daily basis. The risk is increased. And now, in that same study I quoted, 80-something% of the patients have scarification marks. These are social-cultural practices which we need to stop. And that's another means of transmitting this virus. So these risk factors are very common to our environment, and we need to raise awareness and deter our society from transmitting this virus. There are other risk factors, but not so common. If you permit me, I could just run them.
Just do.
Okay, now, diabetes mellitus is another risk factor. Obesity is a risk factor for liver cancer. Obesity, diabetes, then aflatoxins. Now, this one, aflatoxins is a fungi that's embedded in most of our grains and our onions and our stable foods.
Oh, so is it also other things?
It's a risk factor. Yes, not just granules. Apart from granules, common with granules, even your onion, even your other grains. These are fungal molds that are actually embedded in this food. So food storage is another important means of preventing cancer.
Food storage? What do you mean food storage?
No. The immunity actually is what affects the growth of fungal infection of this mold. So we get an ideal means of storing our grains and our onions, etc.
Thank you very much. That is from the gastroenterologist, the risk factors, especially for the commonest, the hepatocellular carcinoma, cancer of the liver. I would like to hear from the endocrinologist. I think every organ in the body
every organ
is for the endocrinologist. The eye secretes everything.
Right.
So, but what are the common cancers?
The common cancers, fortunately, they are not so common. But the common one that we see is people develop enlarged goiter. Or the thyroid gland is small, and because of when it becomes so big that somebody can see it, that's what we call goiter. But most of the time, it is innocuous. It is just big, just like we say, it's just a tumor because it doesn't go from. But like 1% of such population, they may develop a cancer, a thyroid cancer. It's not very common, but it happens. So every time we see goiter in the neck, that swelling in the neck, we also want to check whether there is a possibility of a cancer, one of the cancerous. We look at that. Another one that I don't know whether it is strictly speaking endocrine is prostate, and it is because in men it is one of the most common cancers, and because it's something that we can do something about. I think that it is very important.
What can we do about
We
it?
because an adult male after 40, the prostate is usually it enlarges after 40, unless it is causing obstruction of urine, no problem. But because it is not loud, when the swelling, ordinary simple swelling of the prostate becomes cancerous, it is not loud. Then there is a simple blood test that we can do, regularly.
Yes.
So we say any man above the age of 40 should do a specific a test that is specific for detecting prostate cancer. They call it PSA. That's specific antigen. Yeah. It is easy to do, and well, the price is coming down. It used to be costly, but it's not very costly anymore. But at least once a year. But once you are above 50, it is expected that at least you do it twice in a year, because it is a good indicator. If the level of the PSA is high, it is a strong indication that maybe there is a cancer developing, and then you do something about it. Because if you don't catch it early, it has, like I said, it has a tendency to spread. And once it spreads to other places, well, it may be, the treatment becomes more difficult, and the prognosis is also worse. The other organs that come to the endocrinologist is the pancreas. Yes. Again, because it's deep inside, you may not know until maybe it's too late. That's why every time a diabetic patient goes to the doctor, we should check, is there any all around, is there anything that is amiss? Is there any, if you check the routine tests you do, is there anything to suggest that there might be something wrong? Or the control that used to be good is no longer good, the patient is doing everything right, the diet is checking, is doing exercise, is taking his drugs, and yet you are not getting the expected result. It calls for one to look for that check. But the loudest form of pancreatic cancer is when it has caused obstruction to the bile flow. Then the eyes are yellow, it causes a lot of itching. At that stage, most of the time, it's late.
So
it is better to check.
Okay, I used to say that people should give themselves a birthday gift and check every year around their birthday. But now you say somebody should check twice a year.
Especially once you are
to think about
after the age of 50, yes. Make it twice a year.
Okay.
Make it twice a year.
Just simple checks.
Simple checks
may help us
detect
get to the root of the problem.
Yes.
Or maybe detect it very early. Like I said, that means 1/3 of cancer death can be prevented if we detected it
early.
Very early. Viewers, I would like to remind us of the numbers. When we do open our line, you can call using 0907 111 5342, and at any time you can send a text to 080 321 080 32 91 6880. You can send a text using that number. We will take a break here. When we come back, we will discuss also with another set of specialists. We will discuss with the hematologists, and we discuss with the gynecologists. What are the common cancers? How will you know them? But how will you avoid the risk factors? For now, still stay tuned. Health.
TSTV, connecting your world.
And welcome to Clear Health. Welcome back. You are watching Clear on Health, broadcasting on Africa Health Television on TSTV. Today we are discussing cancers. We just spoke about cancers of the endocrine system and of the gastrointestinal system. And now we will speak about blood cancers and cancers of the female genital tract. I have with me Dr. Mrs. Ekaite David. You can see she's in red because we're talking about blood. You're welcome.
Thank you very much.
We have Dr. Idris Mohamed Liman. He's a consultant obstetrician and gynecologist. By the way, I just said she's blood. She's a consultant hematologist. So we have been talking about cancers generally. But I want each of you to tell us about those risk factors that concern that you feel and the kind of cancers that are there. Maybe we start with you, Dr. Ekaite.
Okay, thank you. I will first start by saying that I'm a hematologist. So hematologists are the doctors that deal with blood and blood diseases. Blood cancers fall under blood diseases. And in blood cancers, we have cancers of the blood, and we also have cancers of the lymphatic systems. And so those are the common cancers. For us, what are the common risk factors, as in other cancers? Things like smoking, alcohol, petrochemicals, radiation. So things that generally cause other cancers are also risk factors for cancers. And then also for us as well, we have treatment from other cancers, especially with chemotherapeutic agents. So for those who end up living above 70, 80, if they were treated earlier on in life for a cancer, sometimes some people come down with a secondary cancer.
What percentage of them?
They are very few.
Somebody doesn't think that if you have
No. It's a very small, and like I've said, it's for those who stay up to 80 years and above. So first and foremost, our life expectancy in Nigeria isn't that high. So in people who had treatment earlier on and they live a lot older, like I said, 80 and above, sometimes it does occur. So what are the common cancers that we see in hematology practice? We have the non-Hodgkin's lymphoma. We have the Hodgkin's lymphoma. Those are the lymphatic system cancers. Then we have the blood cancers. We have the multiple myeloma. We have the acute myeloid leukemia, acute lymphoblastic leukemia, the chronic myeloid leukemia, and the chronic lymphocytic leukemia. Of all the cancers I've listed, the commonest are the non-Hodgkin's lymphoma groups. But due to time, I won't be able to mention them, because due to improvements in science, even the non-Hodgkin's lymphomas have been further broken down to things like follicular lymphoma, diffuse large B-cell lymphoma, and the list goes on and on. So basically, those are the sort of cancers that we deal with. And like I've said, the risk factors. But how do we prevent or detect early cancers of the blood? You had mentioned earlier giving yourself a birthday present of a health check. For us in hematology, things like a full blood count or complete blood count, as it's called, is usually a simple test that picks up a lot of the cancers that we deal with.
Full blood count.
Full blood count or a blood
is
count.
done in virtually every
Yes,
laboratory.
yes,
In
but
even
the
in any
difference,
small place, yes.
yes, but the difference is when you do a full blood count, a lot of people then tend to tell you, oh, they did a full blood count, and then when they are reporting, they'll talk only about the packed cell volume, PCV, HP. But what are the other things that you should look out for? The white cell count, the platelet count. So when those values, any of those values are either too high or too low, it's an indication for whoever went to a lab for a test to go and book an appointment to see a doctor.
Forms will make you know that there's a red flag.
Okay.
The possibility of getting a blood cancer.
So the common symptoms, sadly, are what are common to many other things. So a lot of them come down with fever, with malaise, bone pains. Sometimes they'll talk about having infections. Sometimes they present with bleeding. Depending if their platelets are low, they could come with bleeding. So the bleeding could be menorrhagia, it could be bleeding into the skin, it could be they go and pass urine, it's blood, and things like that. So those are simple things they may see. But like I said, commonest, they would complain of fever, they'd complain of body pains, they'd complain of tiredness, especially if their blood levels are low, they walk short distances, they get breathless, they can't comfortably. And then sometimes some types of cancers that we hematologists manage come with swellings of the lymph nodes, what is referred to in the medical term as lymphadenopathy. And then sometimes some organs get swollen in the abdomen, the liver, and the spleen. So usually we would tell people, if you notice that you begin to see swellings that went there previously, that's an indication for you to go and check, either in the tummy or on any type of the under the neck, in the armpits, or things like that. When you see those kind of swellings or those sort of things, that's an indication for you to go and investigate it to find out what exactly is going on.
Now, some of these symptoms you mentioned are generic: fever, malaria, and so on. They seem to occur in different kind of diseases. But perhaps maybe at this point we will borrow a leaf from those who advertise medication, paracetamol and some others, who say that if symptoms persist after 2
So
days, maybe after a
usually
few attempts, you
what
should
we
look
would
for-
say is, you know, commonest fever, malaria, most people will say it's malaria.
Okay.
So we would usually say, if you think you've had malaria and you've treated malaria once,
Yeah.
it goes and it comes back again very quickly. You treat it a second time, it goes, and then you feel the symptoms again. That is when you need to go and check.
To do a further check.
Yes, to do a further check other than the malaria test.
Okay.
Yes.
How common are these cancers of the blood? Because people have a tendency to think that, I mean, it's difficult for anybody to. If you talk about lumps, it's very easy. You see a lump, you attack it. If you talk about bleeding, it's very easy, you know, for somebody's mind to go there. But are they generally the cancers of the blood and lymphatic system?
Okay, so the cancers of the blood and lymphatic systems are, if we go on the list of cancers, they are not high up, but we would start from, say, number 5, number 6, number 7.
Okay.
But like I said, for some people, and then for some of our cancers, they are asymptomatic. So that's where the tests, like I said earlier, we keep emphasizing the full blood count. That's where it becomes very important, because sometimes it's the full blood count that picks it. They are asymptomatic, they don't feel anyhow, they don't have any complaint. But if they were used to doing yearly blood checks and things like that, then the doctors then tend to see, oh, there's a trend. Something is different. A certain section of your blood is going up or is coming down. We need to check it. It hadn't been like this previously.
No, but since full blood count can be interpreted by many people in the health system, when they see the white cells go up, they say it's infection. When they see the platelets go up or go down, they interpret it on their own. At what range should we say this is now for the health practitioners? At what number, at what value would we say that this white cell count, red cell count, or platelet count is signifying? I believe that there is an overlap with, you know, what is infection and what is.
So, well, you're right. There's an overlap, and then unfortunately, the cancers act differently in different people. So sometimes, normally, for example, the platelet counts, the normal counts are between 100 to 400. Usually, up to values above 50, the patients are not likely to bleed, but they would have been picked up on a blood count. So once the values usually fall less than 100 for platelet counts, there's a need to check. It may not be a cancer, it may be an infection or something else, but there's get it checked out. For the white cell counts, usually we would do values from 3 to about 10. So anything lower or anything higher. But you know, for the white cell count, there's also infections. So usually above 50 is when we would say begin to check. Like I said, there's no general rule, because there are some people that their counts are not even up to 50, but they still have a cancer. So usually what we would say is, if it's out of range, check, get it checked, and let them tell you, okay, this is an infection or it's a cancer or something.
And thanks be to God that the full blood count is a simple test.
Yes.
It's done by many people.
And it's easily available.
Thank
Yes.
you very much. Now, we would like the consultant gynecologist to tell about cancers of the female genital tract. What are they, and what are the risk factors, and how do we try to prevent them, either by our behavior or whatever we get ourselves to do?
Thank you. Cancers of female genital tracts are many, but the commonest ones are the ones that we've been hearing about all these years. Every time people talk of cancer of the cervix, cervical cancer, cervical cancer, that is the most commonest cancer of women, you know, in this part of the world, and second commonest in the entire world. Then we have cancers of ovaries, of the cancer of the ovaries, cancer of endometrium, that is uterine endometrium and the uterine corpus. We have cancer of the vulva and cancers of the vagina. these are there, but they are not as common as in fact, actually the order is in that order of cervix, ovarian, endometrium, vagina, and vulva in terms of its commonness.
So every organ in the
yes, in
genital
fact,
tract
can develop cancer. In
develop
fact, there are
cancer.
some that we have not mentioned, which is very rare. But if you are asked to mention them, you should mention it is cancer of the fallopian tube. You know, from the uterine corpus, we jump to the ovaries inside the abdomen and so on. So these are the cancers of the female genital tract. But suffice to say that women, being in all other forms of cancers that have been discussed so far, can happen in them, including these blood cancers and so on. What is so specific about cancers in women is cancer that is associated with pregnancy, because it's only a woman that can be pregnant and can develop such a problem. We call it gestational trophoblastic disease. That is a cancer form of it, and it can be associated with even pregnancy up to a full time delivery. We call that one placenta-site trophoblastic disease. The general risk factors mentioned for cancers actually also play out in gynecological cancers, but very specific to especially the cancer of the cervix is the age of first sexual intercourse, the age of the number of sexual partners a woman has had, or the number of sexual partners the male partner of the woman has had before.
No, you need to explain this. The number of sexual partners the male partner of the woman has had.
The woman herself, multiple sexual partner is in there.
Okay.
Then, if the woman does not have multiple sexual partner,
a spouse.
yes, who had multiple sexual partners before coming into
that also
relationship,
qualifies for her
another, yes, multiple sexual partners. They are all implicated in the formation of or development of cancer of the cervix. But the most important of all these factors is the human papillomavirus infection. This is a viral infection and is highly implicated in the formation of cancer of the cervix. Science is falling just very short of calling it a cause of cancer of the cervix. So most of these general, risk factors also in other gynecological cancer, but specific to ovarian cancer is, maybe oncogenes coming through the reproductive tract retrogradely through the uterus into the
what are the
fallopian tube.
oncogenes?
These are things like TAC, which can come through the vagina and deposit onto the ovaries.
Okay,
so they can precipitate ovarian cancer.
How will it come through the vagina?
Because
by use by people?
Yes, by use by
when
the
people douche or people use
douching, all those chemicals too. Yes, all can retrogradely go all the way back to the ovaries because there is a
this is very important because some people put different kinds of chemicals in their vagina for different kinds of reasons.
Yes.
Some put it to treat, infertility, to treat bleeding, and to make sex more pleasant. Yes. I think it's very important that everybody listens to this. Yes.
Yeah, I think as a gynecologist, we discourage any interference with the natural milieu, natural setting of the vagina area and so on, except for water. If you need to wash with clean water, probably if you prefer warm water, that is fine. But anything additional to that water, be it Dettol, be it disinfectant, be it lady wash, and so on, we discourage it because it changes the milieu interior of the vaginal ecosystem, and that can result in infections and many other things. Apart from these, far-reaching consequences of getting all the way back to the ovaries. Ovary is mentioned because ovary is a highly multiplying, organ, in the body, and any small trigger can turn off, the controlled multiplication, which is the natural setting of the ovary, to uncontrolled setting, which is the cancerous form in the ovary. So these are some of the things that, and then these chemicals we talked about can also serve as a risk factor for development of both the vulva, that is the outside of the vagina, as well as in the vagina, because they tend to excoriate, they tend to kill off the natural cells that are multiplying in their own program fashion. And once that happens, from natural taking insult of these chemicals, recover and continue normal multiplication to reach a point that this control will start to be affected. Then we have the genetic angle to some of these gynecological cancers. So these are the pool of risk factors that,
okay, so prevention now.
Yes.
Do we have any hope?
Yes.
Is there anything a woman can do to prevent this cancer?
Especially in some, and the commonest ones, I mean, that makes me happy that at least cancer of the cervix, which is the commonest and is accountable for more than getting to 300,000 deaths per year, has a preventive things that you can do to prevent it. And this is categorized into 3 levels. We have the primary prevention, that is what you need to do to prevent, you know, the onset or assaults or insults to the system that can generate the cervix. And the secondary, early detection of, yes, you have not been able to avoid the insult coming in. Insults have come in and it's starting to cause problem. You want to get it very early and then nip it on the bud. And then the third tier, which unfortunately is not what I am very happy to mention, but we have to mention, is that somebody who has got cancer of the cervix already, you have to take care of the disease, you have to improve the quality of life in these kind of patients, even though it may not be that you have cured the cancer, but somebody will have to, you know, treat the cancer and then live a quality life and so on. So these 3 levels are common. One, prevention of insult is, first of all, avoiding those risk factors I've mentioned earlier on. Maybe delay in sexual debut, avoiding multiple sexual partners, avoiding, some may not be avoidable, but I think the entire system can also work on it to improve, like low socioeconomic status. Yeah. This as associated, is a risk factor. Then, you know, when you avoid this, then you prevent what will result in infections, you know, general infections, including the human papillomavirus. Then the secondary, you know, prevention.
So what do you do to prevent human papillomavirus infection?
We have a vaccination. Okay. Yeah, so there is vaccine. There are vaccines to it. We have Gardasil, pentavalent. We have Gardasil nanovalent, and we have Cervarix, which is bivalent.
So are you saying that if I give this vaccine to my girls, or to boys?
Both to boys, and girls.
Boys and
yes,
girls.
Yes.
Okay.
But it's developed for the girls majorly, but it's found to have effects in, you know, certain conditions in the boys as well. So it's preferably given before sexual debut, usually at the age of 9 or between, you know, 10 to 12 years. Yeah. And if perchance you miss that opportunity, there is catch-up, you know, period. You can still give it for both the boys and the girls. It's given in 3 doses, and it's sent to prevent the major species of human papillomavirus that are oncogenic, that can result in, you know, malignancies of the genital tracts, and that is ranging from 6, 11, 18, 13, 18, 33, 31, 33, 48. So once you give it, and it prevents those oncogenic processes, you know, from coming up. Yes. Now the other ones that is actually the vaccine for early detection of pre-malignant conditions. Yeah. Then we have those secondary level of prevention that include, you know, looking through to the cervix. We call it visual inspection by acetic acid, VIA or VLI, using Lugol iodine. These are simple, you know, examinations that can be done one stop over in a clinic to check. And it just requires some form of treatment. It doesn't have to be done by a gynecologist. somebody who has been trained on how to do it and knows how to interpret the findings can. Yes, so it
now,
is
I want
advised.
to know, are there cancers that are curable? And I would like the hematologist to also answer that before we take a break. Are there gynecological cancers that are curable?
Well, cure is a relative in this, is a definition.
Okay.
Yes, no, the cure
Means
does not settle with,
you got
as
the
if you have
cancer,
malaria, you
it was
treat malaria,
treated,
it's gone.
and the cancer goes.
Well, the only one that I can mention curable in that fashion is actually the gestational trophoblastic disease, you know, choriocarcinomas and co. Once you have identified it, you can treat it, and then you monitor using beta HCG to determine at a point which you have attained cure. There's no single trophoblastic cell producing excess human chorionic gonadotropin, the total cure. And that is what I believe most audience want to or understand by cure.
Yeah, but because
but
it's
in
good
cancer,
to understand that something can be cured.
yes. But in cancers generally, what the oncologists, I'm sure when it comes on board, they will tell us what they mean by cure. Cure may mean having completely stopped the process or halt the process and delay, you know, the veracity or the speed with which cancer lead to, you know, termination of life, and then giving the patient a good quality of life. So
Okay,
it depends on which cancer you are talking about.
Yes.
It is, there are scales in which they will say at this point I think we have
degrees
attained it.
okay.
Yes, sir.
Are there cancers that are curable, that are from
Well,
blood or lymph?
the first thing is that for you to even start to think of or talk of a cure, we must talk about early detection.
Okay.
So it needed to have been picked up early. So as you know, I'm sure the oncologists will talk more on it. You have the grades of the disease, the stages, stage 1, stage 2, stage 3, like that. And then there are different staging of the disease. So when you talk about cure, it has to be an early disease.
Okay.
So we are talking about stage 1, stage 2. So science has advanced so much, and science is still advancing. In the hematological space, we have things called bone marrow transplant for the blood cancers. But like I said, it has to be picked up early. And also we know nothing is 100%. But with those, so we have those kind of things, bone marrow transplant procedure. Now we are talking about gene. We're also talking about gene therapy procedures. And then also with advancement of science and study of genes, the new drugs that are being produced are actually targeting the genetic defect. So all these sort of things that are becoming more and more available, that they live longer, they live better lives, and they have good quality life while being alive and living with the cancer.
Thank you very much. Viewers, you have been listening. I think there are take-home points that is not all cancers that when they come early, there is better hope, and that if they are prevented, that is the best that can happen. When we will take a break, when we come back, we will listen to the oncologist speak to us on cancers in a newer perspective. Thank you very much, Dr. Ekaite. Thank you very much, Dr. Liman.
You're welcome.
It's a pleasure you here.
Thank you very much.
We go on a short break now so that we will take the last segment of this discussion. Good evening and welcome back to this discussion on cancer. This is Clear on Health, airing on Africa Health Television on TSTV. We have discussed with different experts about cancer prevention and what people can do to help themselves pick up the earliest part of cancer so as to save themselves. 4th of February, like we said early, is the World Cancer Day. And the theme for this year is closing the gap in cancer care, and particularly trying to define what problems there are in care and removing stigma, and then listening to those who are living survivors of cancer. With me in this segment is Dr. Bello Abubakar Mohammed. Dr. Bello Abubakar Mohammed is a consultant oncologist in the National Hospital Abuja, but he also presently is on sabbatical, yes? He is running Bella Medical Consultants in Jabi. Bella Medical Consultants is a standalone cancer treatment center and probably the only one of such type in Abuja, or one of the few that we have in Nigeria. Dr. Bello Abubakar Mohammed is also the president of the African Organization for Research and Training in Cancer. You are welcome, sir.
Thank you so much. Thank you for having me.
Listening to this topic, maybe from your organization, African Organization for Research and Training in Cancer, you know, people say there is not much research going on in cancer, and there are very few centers that are also training in cancer. What does the organization do? Has the organization come up with anything on research on cancer, or how we should treat our cancer, or just how, before we talk about the theme of the World Cancer Day?
Thank you very much for that question. Let me take you through history lane on how the organization was actually formed in 1982 in New York by mostly African scientists living in the diaspora. About 5 of them came together, led by late Professor James Holland, who is a renowned cancer specialist. He has published a lot of textbooks in cancer, and they came with the understanding that there is a need for training as well as research in cancer in sub-Saharan Africa. And that's why the name came about, you know, African Organization for Research and Training in Cancer, otherwise called IOTIC. Now, since 1982, we have evolved. We started with very few people, and in the last count, we have almost about 3,000 members from around
3,000 oncologists in
from around the world, from around the world, only in sub-Saharan Africa.
Okay.
And it's not only oncologists that are involved. We also have scientists that do research. We also have advocates, you know, cancer advocates that are also involved, you know, in the cancer space. So basically what we do is multifaceted, but we do have subcommittees. Most important ones, I must say, is education and training, as well as the research committee. Over the years, we have evolved. What we have been doing primarily is to train people on understanding research, whether research is in clinical trials or in publishing and so on and so forth. And we have developed a very robust clinical trial committee that last year we had a very big conference, the first IOTIC Genomic Conference, where a lot of people from around sub-Saharan Africa and indeed from the diaspora have come down to showcase their research. So yes, there are a lot of researches that have been going on. I'll give you an example of one.
Certainly. So you have a regular conference.
Yes. So we do. Yes. So yes.
Ideas.
Yes.
But
So
have you produced any document that guides people on cancer treatment in
Africa,
Africa, or do we invite the world one
So absolutely, what we try to do is to collaborate with a lot of organizations from around the globe. The National Comprehensive Cancer Network of the United States that produce guidelines for cancer centers in the United States actually collaborated with Africans to develop the NCCN harmonized guideline for sub-Saharan Africa, which IOTIC members have been part of. I happened also to be part of that guideline, and I chair the guideline in prostate, colon cancer, rectal, and other cancers. So we have guidelines, and I'm happy to note also that the Federal Ministry of Health has actually endorsed that guideline as a national guideline for Nigeria. And many other countries have also, adopted those guidelines. So we do too many things here.
That's good news. Well,
yes.
Maybe moving away from African Organization for Research and Training in Cancer, let's come back to the World Cancer Day. When it was set up in 2000, it was hoped that each year we would discuss about cancer. And this year is saying closing the gap.
Yes.
Especially trying to diagnose what are the problems, what are the gaps. Okay, for care for a cancer patient in sub-Saharan Africa, what are the gaps? I feel heavy asking that question because it looks to me that there is gap everywhere. But I have a hope that you people are making research. But what are the gaps? What constitutes the gap?
So thank you very much. That's a good question, and to be able to answer you will take the whole day, or another day. But let me quickly summarize of the gaps that we have. Yes. If you look at the countries, what we have encouraged countries to do, even from IOTIC and from other organizations, is to develop what is called the National Cancer Control Plan. Nigeria has one. Some of the things that are involved in the cancer plan are: 1, prevention; 2, diagnostics; and 3, treatments; and 4, palliation. So when you look at issue of prevention, you talk of screenings, you talk of vaccines, and so on and so forth. You talk of diagnosis. So you look at all the things that you need to do, whether it is imaging, whether it is pathology, and so on, to make a diagnosis of cancer. And then you look at treatment. Treatment of cancers, whether it is going to be surgery, whether it's going to be chemotherapy, whether it's radiation, and so on. And of course, you look at palliation. You talk of things that you need to palliate, whether you are talking of pain management, the use of morphine, and how it is made available, and so on and so forth. So when you look at this everything critically and ask yourself, what are they? They are significantly huge, very huge. And like I said, it will take a long time, but let me just quickly touch on one. Just one, which is the radiation therapy machine. Why am I worried about radiation? Because 70% cancer patients will require radiation at one point or the other in their cancer journey. Because in sub-Saharan Africa, 86% of our patients present late at stage 3 or 4. So will require radiation therapy. You look at the continent of Africa, which has a population of about 1.3 billion people. We will require about 5,000 radiotherapy equipments. We don't have that much. In fact, the only 2 countries in the whole of sub-Saharan Africa that will say they have some suboptimal number of equipment are South Africa and Egypt. Coming down to Nigeria, with a population of about 200 million people, we will require a minimum of 200 radiotherapy machines. We have less than 10. So you can have the picture. Yes. So the gap is 190 that we need to fill in to be able to provide some optimum standard of care for patients that are living in sub-Saharan Africa, mostly third world countries. So this is just radiation therapy. Yes.
And there are other things.
And there are other things.
I won't want you to mention more, but because of time, I just want to ask a question. Somebody has cancer. Any hope? What are the new developments that can make people to be hopeful that maybe very soon we will be able to have,
Yes.
good treatments about cancer.
Right. So you do know that the four pillars of cancer care in itself is one, treat those that are treatable, cure those that are curable, palliate those that are cannot be cured, and there is one other one I cannot remember. So if you look at this, the treat those that are treatable is different from cure those that are curable. So cancers that are detected early are mostly curable, but it has evolved now to personalized care. So we have personalized cancer care now, where you will go to the hospital, they will do a biopsy and confirm that yes, you have a cancer, then they will want to know the subtype. I'll give an example with breast cancer. Before now, every breast cancer patient that goes to the hospital is treated with tamoxifen. It's a hormonal therapy. Not anymore. There are those that don't benefit from tamoxifen, because we do know now that we have 4 subtypes minimum of breast cancer, and this is based on the immunohistochemistry status of the patient. So if a patient has a triple negative breast cancer, he will not benefit from any hormonal treatment. He will only benefit from chemotherapy as well as immunotherapy. So these are the new evolving things. Immunotherapy has evolved since the creation of PICE, which is Parker Institute for Cancer Immunotherapy. Actually cleared.
Our current economic, financial realities and whatever, what are the lowest hanging fruits that we could easily do to help, cancer patients or to prevent cancer and all that?
So for me, it will be to first and foremost develop capacity, because it is lacking in this country. We have less than 100 clinical oncologists practicing in this country, and we need 3,000.
We have less than 100?
Yes.
Let's say we have up to 100.
Yes.
Over
1,000.
3,000.
So we still have a gap. So the
Okay.
gaps are there.
Okay.
So I will suggest
Yes.
that because you cannot develop 200 radiotherapy machines overnight, we have 6 geopolitical zones. We will build a standalone cancer hospital that will be equipped to provide care, prevention, to provide treatment, standard treatment, as well as to provide palliation.
It is
In
your field.
4,
It's
yes.
your field.
So
I
we
think
should be.
you know that were there no attempts to have a standalone cancer hospital in Nigeria?
Well, I'm not too aware. What I do know is that most of the ministers, and I had the privilege of working with some ministers who have actually wanted to fund or provide equipment to the hospitals that have already a cancer department. That's the difference between this country and many countries of the world.
Yes.
What we have a cancer department in hospitals. Even have bargaining power.
Yes, and maybe more research.
Yes,
can be
and
done.
more research can be done.
I agree with you, because hanging fruit should be training
Yes.
personnel, but we have many
So
hospitals.
when you have a standalone,
Yes.
the chances of having more people trained and faster to will be better than when you have a hospital that is saddled with training in all other departments. So that is one other aspect. The other aspect is you will attract funding. I'm sorry to say, where I practiced, we don't have a grant office. Last year we missed $250,000 because we couldn't just have many, some of the things that registration that the NCI actually wanted. So if you have cancer hospital standard, if you go to the United States, most of the cancer hospitals that are doing the research and doing fantastic things, like Mayo Hospital, is standalone. If you go to MD Anderson, it's standalone, and so on and so forth. Fox Hospital, name them. They are mostly standalone. So you must be able to do that. That's the first thing. Well, I think it's a low hanging.
Well, Dr. Bello, thank you very much for your perspectives on cancer.
Thank you.
And we wish you well on World Cancer Day.
Thank you.
And we wish that everybody will put his hand on deck. For us, we are trying to enlighten everybody, those who take care of cancer patients, those of us that probably don't know anything, so that we will know a little and be able to prevent cancer for ourselves, for our wards, and for everybody that we are responsible with. With that, we'd like to close this program this evening. I am grateful, Dr. Bello.
Thank you so much.
Also grateful for all the other guests that came, and I'm grateful to the media team. This is Clear on Health, broadcasting on Africa Health Television. Good evening. And welcome to Clear on Health.